Well, we've recently coined the phrase interventional pharmacoeconomics to refer to a new discipline. And the discipline basically applies clinical pharmacology knowledge in order to reduce the costs of prescribing drugs, and with a particular focus on oncology, although that's certainly not the only focus. As a proof of concept, the ophthalmologists developed the use of off-label bevacizumab to treat macular degeneration, and that's now the most commonly prescribed VEGF inhibitor to treat macular degeneration in the United States. It's been limited, for example, here in the UK by the courts and litigation from Novartis, but my understanding is based on a recent British Medical Journal commentary that now ophthalmologists in the UK can prescribe bevacizumab off-label, which is less than 5% the cost of alternative therapy. So that this has been around in the United States for a long time, and it's an example of how physicians can utilize drugs off-label, not in the traditional sense of treating conditions for which there are no approved drugs, or perhaps using higher dosages to improve efficacy, but really to utilize drugs in ways that the manufacturers had not envisioned and in general don't endorse, often the use of lower dosages of drugs or giving drugs less frequently, which can reduce both side effects and costs both to the system, the payer, and potentially the patient, depending on the healthcare system. Well, the key take-home message of my talk was that there are dozens of opportunities in oncology for which their drugs are labeled at a dosage that is too high. For many of these drugs, the approved dosage is more than 100% too high. And I gave some specific examples. I think the most relevant example is the example of the drug atezolizumab, a drug that was recently turned down by NICE for funding based on cost effectiveness. Atezolizumab, when administered at the dosages in their approval, which is giving the drug every other week, the average concentration achieved in the patient before each dose is over 200. The company has previously published a paper saying that all you need is 6, maybe even 4. So again, here's an example where just a small fraction of the approved dosage should be effective. And if there were strategies developed to utilize this drug, and whether one takes these single-dose vials and finds a way to share them across patients, or an alternative strategy that we recently wrote about is just using the standard dose, but giving it a lot less often, perhaps even measuring the drug concentration in patients, and using that information to decide when they need another dose.